Good evening, doctors. Welcome to this webinar series organized by Park Clinic and DigiNeuro. This webinar series is coming to you. This is the third episode of the webinar series. And the title of this webinar is Control of Micturition. What can go wrong? This webinar series is coming to you through a digital initiative by Health and You, a joint venture with Newlink Company Limited Japan and Park Clinic, Kolkata. This webinar will be posted on YouTube channel of ours, which is DigiNeuro. We have more than 56 webinars on this channel with international national speakers with about 500 plus subscribers. So please come and join us as subscribers like this YouTube channel. Quickly, I will introduce to you our brands from Health and You. In epilepsy management, we have Brinda, Brivaracetam, patients truly, 25, 50, 7500. We have Clobazam, Air Clobaz, with a new strength, 2.5 milligram, 5 milligram and 10 milligram, add flexibility, add control. In headache and migraine management, we have Amnurite. First time in India, amitriptyline plus mecobalamin combination, Amnurite 5, 10, 25. We have a new concept in migraine, vitamin therapy for migraine, Bentamin, riboflavin 200, magnesium 200, and CoQ10. We have, again, first time in India, an innovative product, amitriptyline plus propranolol combination, Amnurite Beta 520ER and 1040ER. Recently, we have launched a rapid-acting naproxen with domperidone, ND-RAP 500-250. 99% of naproxen gets dissolved in just 30 minutes for rapid action and rapid relief. In neuropathy management, we have Amnurite, Amnurite P with pregabalin sustained release formulation, Neurite injection imported from Japan, mecobalamin injection, and Neurite D for diabetic peripheral neuropathy. In vertigo, you have a very, very specialized, only specialist molecule, beta-histine mesylate, 6 and 12, less is more, 25 milligram best strength in this salt, beta-histine mesylate for vertigo. In stroke, post-stroke management, we have Neurite Active, and for spasticity, we have Backrite 10, 20 XR, 30 XR, very, very small tablet as compared to what is available in the market. That's about it. I have now great pleasure in handing over the session to our coordinator, Dr. Kaushik Sil. This entire webinar series is conceptualized by Dr. Sandeep Chatterjee and coordinated and brought to you by Dr. Kaushik Sil, Associate Professor and HOD of KPC Medical College and faculty of Park Neurosciences, Park Clinic, Kolkata. Over to you, Dr. Kaushik Sil. Thank you.
Thank you, Deepak. And on the behalf of Park Clinic, it's my honor and pleasure to invite you all to this interesting webinar sessions. As you know, we are conducting this Basics in Neurosciences webinar for the last 2 weeks, and this last 2 episodes, and this is the 3rd episode. And the topic is very interesting today, that is on control of micturition. As you know, we all have studied this physiology of control of micturition during our physiology days. But as we go in our day-to-day clinical practice, and you see variety of patients with neurogenic bladder and other types of bladder dysfunctions, as practicing neurologists and neurosurgeons, we occasionally are caught up in a dilemma about which type of pathology it is, how to deal with this, and especially for the young neurosurgeons or neurologists will be appearing for an exam, you should have a clear idea about about the physiology of bladder, the neural control of bladder, and what can go wrong. What is the basics of this? And to hopefully after this session, you will be in a better position to understand all this. And without wasting time, I'll introduce us to our guest speaker of today, Dr. Tapas Kumar Banerjee. He is one of the distinguished and senior most neurologists of the city of Calcutta. He is a director and chief consultant neurologist at the National Neuroscience Center, Kolkata. Dr. Banerjee will be accompanied by 2 eminent personalities, Dr. Himadri, who will be the panelists of today. Number 1 is Dr. Himadri Pathak. He is a consultant neurological surgeon of Ramakrishna Mission Seva Pratishthan and Park Clinic, Kolkata. And we'll have shortly Dr. Atanu Biswas joining, who is a professor of neurology at the Angud Institute of Neurology, Kolkata. So I will request Dr. Tapas Kumar Banerjee to go ahead with his talk. He is a speaker of today's topic on control of micturition, what can go wrong. Over to you, Dr. Banerjee.
Thank you very much, Dr. Sil, and good evening, friends. And at the outset, I must thank the sponsors for hosting this very interesting session. I've been assigned a task to talk about this very interesting but a little bit of a difficult topic. It's a pretty onerous task for me because this has to be finished within 20 minutes. That's the time allotted to me. I'll see if I can do justice to that topic. So the talk is on control of micturition. What can go wrong? Right. Can you see my slides?
Yes, yes.
Yes. Is it visible? Okay. All right. Thank you. So now urinary bladder and the bladder sphincters are innervated by three sets of nerves here. One is the sympathetic nerves. The sympathetic outflow originates at D11 to L2 and it passes along the hypogastric nerve and it supplies primarily the internal urethral sphincter and the bladder neck and also to some extent the bladder detrusor muscles. The function of the sympathetic is to contract the urethral sphincter, internal urethral sphincter and the bladder neck and all relax at the same time the detrusor muscles. Then you have the parasympathetic outflow that originates from S2 to S4 and it passes through pelvic nerves and it supplies directly the detrusor muscle of the bladder and stimulation of the parasympathetic nerves allow contraction of the detrusor muscles. Next we come to the somatic efferents. Here the motor neurons originate in the ventral horns of S2 to S4, what we call Onuf's nucleus. And then these somatic efferent nerves pass through the pudendal nerve and it supplies the external sphincter, leading to constriction or contraction of the external sphincter. So what happens in the voiding reflex? The pelvic sensory nerves takes the sensation of filling and then it reflexly stimulates the pelvic parasympathetic efferents leading to detrusor contraction. And this particular reflex is called vesicoparasympathetic reflex. At the same time, the pelvic sensory nerves actually have an inhibitory influence through the hypogastric nerve in the sympathetic efferent activity. And so at the same time, when this bladder is being squeezed, the internal urethral sphincter and the bladder neck gets relaxed because pelvic sympathetic nerve is inhibiting the sympathetic outflow. At the same time, the pelvic sensory nerves is inhibiting the function of the pudendal somatic activity leading to relaxation of external urethral sphincter. This reflex is vesicopudendal reflex. So that's how the voiding reflex is carried out. Now the other reflex is the urine storage reflex. Here, there is relaxation of the detrusor muscle of the bladder. So that means the parasympathetic outflow is inhibited. At the same time, the sympathetic fibers take the upper hand. The stimulation of the sympathetic efferent activity leads to contraction of internal urethral sphincter. And this reflex is a vesicosympathetic reflex. And the contraction of the external urethral sphincter also occurs through the pudendal motor activity. So the function overall here is to store the urine in the bladder. Now, all these reflexes are under the influence of higher centers. So whenever the pelvic sensory nerves take the stimulus, it doesn't act reflexly without any influence on it. It has to have the influence and the permission from the higher central nervous system centers. So the sacral afferent input goes to the periaqueductal gray, and the periaqueductal gray in the suprapontine region. And that periaqueductal gray is again under control of many centers in the cortex. Prefrontal cortex, the anterior cingulate gyrus, insular cortex, and also the basal ganglia, thalamus, hypothalamus, cerebellum. They control this periaqueductal gray. The reason of controlling the reflex activity of the bladder is because in the individual, in persons, if we have a sensation of voiding, we can't sort of void reflex. We have to find the right place and time to void. So the inhibition from the higher center here prevents us of voiding reflexly anytime it happens. Once we find the right place, then this inhibitory influence of these higher centers allow the periaqueductal gray that, okay, fire the voiding reflex. So what periaqueductal gray does at that time, it in turn stimulates the pontine micturition center, and the pontine micturition center lets the reflexes to set in. So that's how the reflex of voiding is being controlled by the central nervous system. Right. Okay, so what is a neurogenic bladder? Neurogenic bladder means there is the urinary dysfunction is due to disease either of the central or peripheral nervous system, thereby hampering the normal activity of voiding and urine storage. So here you can see this diagram shows that we have a pontine micturition center at the pons. If there is a lesion in the suprapontine region, that leads to uninhibited bladder. Then if we get a lesion between the pontine micturition center and the spinal cord at the level of S2, we say we have a upper motor neuron bladder or spinal bladder. Then at the level of S2 to S4, depending upon where the lesion is, we can get a mixed type A lower motor neuron bladder problem or mixed type B lower motor neuron bladder problem. And then in the peripheral nerves or in the cauda equina, if we have a lesion there, we have something called atonic bladder. So I'll take this one by one. Here we come to uninhibited bladder. So the lesion is in the suprapontine level. So if we have a problem like frontal lobe or parasagittal SOL or ACOM aneurysm, usually the frontal lobe takes the upper hand in controlling the pontine micturition center. So many a times a pathology in the frontal or prefrontal cortex leads to this uninhibited bladder. So frontal lobe or parasagittal SOL, ACOM aneurysm, normal pressure hydrocephalus, Parkinson's and Parkinson's plus syndrome, all the different types of dementia disorders, all these have a problem in leading to dysfunction of the higher centers upon the pontine micturition center. And what happens in that case? We have urgency at low bladder volume. As the bladder fills up to a little bit, the inhibitory influence is taken off and the bladder voids. So what is this phenomenon is due to Detrusor Hyperreflexia, or what we say overactive bladder. Suddenly there may be uncontrollable evacuation. And the evacuation is full evacuation, no residual urine. So no risk of infection. Next we come to spinal bladder. It's an upper motor neuron bladder. And the spinal cord lesion may occur anywhere between the pontine micturition center and the sacral spinal cord. It can be from trauma, from spinal cord structural pathology, demyelinating lesions, and so there's a wide variety of causes which can lead to upper motor neuron bladder problem. And you see here, if it happens above the level of T10, the spinal bladder is more pronounced. And if it happens below the level of T10, the spinal bladder is less prominent because the sympathetic outflow is also jeopardized. So I will show you how that manifests, the spinal bladder. Manifests this entity, we call it detrusor sphincter dysynergia. What happens in spinal bladder is that the detrusor muscle is overactive, it's contracting, and the urinary sphincter is also contracting at the same time. So there is a simultaneous contraction. So what happens? The bladder muscle is contracting against a closed sphincter. So it leads to the generation of a very high intravesical pressure, and then we may get the vesicouretaric reflex. The way for the urine to go is upwards. There is a vesicouretaric reflux, and consequently there may be renal damage. Both bladder and sphincters are spastic. The maximal bladder volume achieved is 250 ml. And sometimes the sphincter can relax a little bit intermittently. So you can get reflex emptying of bladder may occur without warning. But then again, the evacuation may be incomplete because again the sphincter squeezes and the bladder voiding stops midway. So as I said, DSD, detrusor sphincter dysynergia, is especially noted if the lesion is above T10. Because if the lesion is below T10, the sympathetic fibers are affected also. And sympathetic fibers control the internal urethral sphincter. So if the internal urethral sphincter is not tightly contracted, you may get some amount of urine coming out. So there are three subtypes of detrusor sphincter dysynergia. Type 1, increased sphincter activity during detrusor contraction, which seizes the detrusor pressure, decreases to allow urination. As I say, that sometimes the sphincter activity relaxes, detrusor contracts, some amount of urine comes out. This is a type 1. Then type 2, there is a clonic contraction intermittently during voiding, causing intermittent urinary stream. And type 3, there is a continuous sphincter activity during detrusor contraction, resulting in inability to void or urethra. So type 3 has the highest risk of developing vesicouretaric reflux and subsequent kidney damage. Now you see the mixed type A neurogenic bladder. Here the sacral cord lesions damage the detrusor nucleus but spare the pudendal nucleus. And what does detrusor nucleus do? The parasympathetic outflow comes from the detrusor nucleus. Pudendal nucleus is intact. So how that will be manifest? Clinically, it will manifest as a very large bladder because the detrusor muscle is not being squeezed by the parasympathetics. It has a very low pressure because the bladder keeps on bloating up. And so the intravesical pressure is not raised so much. At the same time, the external urethral sphincter becomes spastic. So this leads to urinary retention. Upper tract damage with vesicouretary reflux doesn't happen because the intravesical pressure does not go up to a large extent. Incontinence is uncommon here. Now, mixed type B neurogenic bladder, here the sacral cord lesions spare the detrusor nucleus but damage the pudendal nucleus. So obviously what will happen? The bladder capacity is low because pudendal nucleus is damaged. So the external sphincter is relaxed all the time and the patient becomes incontinent. The bladder capacity is low, vesicular pressure usually not elevated because the voiding reflex is very good, the parasympathetic are good. So the patient gets incontinence all the time. Now we come to atonic bladder, the lower motor neuron lesion here. Here the lesion is either in the cauda equina or in the peripheral nerves in the pelvis. It may happen from lumbar disc disease, spina bifida, pelvic surgery or pelvic tumors. All these lesions leading to either damage of the cauda equina or the peripheral nerves in the pelvic region. So what happens there? The lesion destroys both the sensory and the motor components. of the nerves. So because the sensory is also gone, there is no bladder sensation, and the patient manifests with a large atonic bladder. The thoracic sympathetic nervous system outflow to internal urinary sphincter is intact. So here, some amount of sort of contraction of the sphincter, the internal urethral sphincter contraction is there because the sympathetic outflow is spared. So considerable residual urine is there, risk of infection is high. Sometimes there may be overflow incontinence because if the bladder gets too full, there may be a little bit of pressure developing within the vesicle. The external urethral sphincter is not intact, so that some amount of relaxation is there. If that overcomes the internal urethral sphincter pressure, there may be overflow incontinence. And other neurological problem does occur, like perianal numbness, loss of sexual function. So atonic bladder is a way that it manifests if the lesion is in the cauda equina or in the peripheral nerves. Another entity which has all these years been under-recognized, but now has been understood to be a very common disorder among the elderly, and that entity is Detrusor overactivity with impaired bladder contractility. Here what happens, there is frequent but weak involuntary Detrusor contraction, leading to incontinence, but the bladder emptying is incomplete because the muscle power of the Detrusor is not that great. The sphincters are also a little bit leaky, so it contracts, leading to some amount of bladder emptying very frequently. And classically, pathologically, we have trabeculated bladder. Detrusor overactivity with impaired bladder contractility is another entity that is now been recognized among the elderly. So with all the different types of lesion in the background, how do you investigate a neurogenic bladder? I think my succeeding speaker will talk in details about the urodynamic study. I'll just touch upon it. One of the urodynamic study we do is the cystometry. We record the pressure-volume relationship of the bladder. The true pressure produced by smooth muscle of bladder is calculated by subtracting the intra-abdominal pressure from the intravesical pressure. And cystometry, which shows an abrupt rise of Detrusor pressure to 90 centimeter water, even after filling 100 ml. We say this is an indication of Detrusor overactivity. Now, we have to rule out obstructive pathology in this case before we can say this is Detrusor hyperreflexia due to neurogenic bladder. So all these results has to be interpreted excluding the obstructive pathology of the bladder. Delay in bladder emptying could not differentiate actually the obstructive from the neurogenic cause. Another urodynamic study that we do very commonly, maybe in the outpatient basis, is the uroflowmetry. It is a much simpler way of doing it. What you do, you determine the urinary flow rate, void in full capacity condition in a receptacle with spinning wheel at the bottom. Urinary flow slows the rate of rotation, where from the graphical representation is derived. Here you see this lower tracing shows that the rate of urinary flow, it reaches a maximum of 40 ml per second in 3 seconds and then declines. The upper tracing shows the integration of the flow rate, and it can calculate the total of how much urine has passed. This also has to be interpreted by excluding obstructive pathology, where you can see that this sort of, if there is a dysfunction, the uroflowmetry, this is due to neurogenic bladder. So this is a pattern we see in the Detrusor sphincter dyssynergia. You can see here in this case, there's frequency and urgency, also difficult in voiding. The interrupted flow pattern. You see intermittently, the sphincter relaxes, a little bit of voiding occurs, and then it squeezes again, the voiding stops. Then it comes again. So this peculiar pattern, intermittent voiding pattern, happens in detrusor sphincter design in general. Another way of doing is bladder lick point pressure. We see the maximum detrusor pressure measured during passive filling before urine leakage occurs. And if there is sustained high detrusor pressure in neurogenic bladder, if the lick point pressure is over 40, then there is a high risk of developing upper urinary tract damage because of vesicoureteral reflux. We also do all these different investigations to identify the cause or the pattern of neurogenic bladder. We definitely do an ultrasound scanning, including post-void film for residual bladder volume. This is one test, the neurophysiological test, or this is an extremely difficult test. I'm sure there is no place in our country where this is done. In England also, there are few places I knew of where this electrophysiological test of sphincter and pelvic floor were done. What they do is the EMG of striated muscles of pelvic floor to show denervation. The sacral reflex measurement is also something which is done as part of research. It's not very regularly being done. Neuroimaging, of course, is mandatory of brain and spine, including cauda equina. And if you are thinking that the peripheral nerves, the pelvis are damaged, you can go for CT scan of pelvis. So how to manage neurogenic bladder? Now you can see the various receptors that we have in the bladder wall and also in the urethra. Now, these muscarinic receptors, right? Muscarinic receptors where the parasympathetic work. And the parasympathetic function by squeezing the bladder is through the muscarinic receptor of the bladder. So if you have anticholinergics, which are M3 muscarinic receptor antagonists, like tolterodine, oxybutynin, trospium, that works here and leads to relaxation of the detrusor overactivity. Now, the sympathetic works through beta-3 receptors. These are adrenergic receptors. And the sympathetic activity is to relax the bladder wall. So if we have a beta-3 adrenergic agonist, like mirabegron, that will also work by mitigating detrusor overactivity. Now, so by combining sometimes this muscarinic receptor antagonists like tolterodine, oxybutynin, and the mirabegron, we can have a good result in overcoming detrusor overactivity. But if incontinence is still a problem, what you can do is sometimes if you think that the person is going out and he needs to be quite clean and dry, then you can use synthetic antidiuretic hormone, desmopressin. Single dose in 24 hours has to be used. You should not go more than one dose, otherwise there is a risk of water intoxication. The second line therapy, if the previous therapies fail, then you can diaphragm the bladder. Intravesical vanilla oil like capsaicin, arrest, iniferatoxin can be used. It's not probably used in our country. The one which is used in certain centers is intradetrusor injection, is botulinum toxin. It's pretty effective, very expensive, but it is effective. Through a cystoscope at 20 to 30 different sites in the detrusor muscle wall, you give this injection, avoiding the trigone, of course, and that increases the bladder capacity and virtually eliminates the sense of urgency. The effect lasts between 6 to 9 months. In some refractory cases of overactive bladder, you can do that. Sublingual cannabis spray can be used. Neuromodulation like sacral root, pelvic plexus stimulation may be in very few centers. This is used. Then how to treat detrusor sphincter design? It's a very challenging problem. Now, people have done alpha-adrenergic blockers like tamsulosin, terazosin. The alpha-adrenergic blockers are on the sympathetic, it works on the sympathetic receptors on the urethra, internal urethral sphincter. And by using this alpha-adrenergic blocker, you can relax that internal urethral sphincter, like tamsulosin, terazosin can work there. Or you can give Botox injection weekly in the external sphincter using cystoscope 2 to 4 places at a time. So here you are hitting the external urethral sphincter with Botox, thereby relaxing it and allowing the person to work. Endoscopic urethral sphincterotomy may be tried, but then again, there will be a leakage all the time. So ultimately, the best option is clean intermittent self-catheterization. That's the mainstay of treatment. Atonic bladder, what are you going to do? Bethanechol is a muscarinic receptor agonist. It directly works on the muscarinic M3 receptors. The function of it is to contract the detrusor muscles. So in atonic bladder, you can use bethanechol, Eurotool, or this medicine is what it's called. It stimulates bladder contraction, but it is not very effective. I think the best option that we have left is clean intermittent self-catheterization 2 or 3 times a day. Now, in advanced neurological disease, patient is bedbound. Our option is to go for long-term indwelling catheter. Silicone catheter with a size of 16 F usually is preferred and has to be changed at least once every 3 months. Ultimately, the patient, we have to resort to that in a patient who has advanced neurological disease with very advanced neurological. Recurrent UTI from intermittent self-catheterization or from long-term catheter may be an issue. If acute UTI occurs, you should give short course of antibiotics. Sometimes people go for long course, changing antibiotics in a low dose, but it's not usually recommended because it has the risk of generating multi-drug resistant bacteria. So asymptomatic person with urine culture positive should not be subjected to antibiotics because this neurogenic bladder will be there and the catheterization is prone to grow microbes without true infection most of the time. So if you keep on giving antibiotics very frequently, there is always the risk of generating multi-drug resistant bacteria, and then the patient will have a horrendous UTI which will not respond to any of the antibiotics, and then that will be bad news. So with this brief overview, thank you very much, and I'll wait for the questions. Thank you.
Thank you, Dr. Banerjee, for keeping it so comprehensive but so simple. Now, before we start the questions, I will invite Dr. Pathak, one of our panelists and an eminent urological surgeon, to give his overview on urodynamics. As you know, the urodynamic study, interpreting urodynamic study is a very sore point for neurologists and neurosurgeons. And Dr. Pathak will make it lucid for us. Over to you, Dr. Pathak.
Good evening, everybody. Good evening, sir, Dr. Tapas Banerjee. What a beautiful resume of a massive subject which you have been able to bring down in such a short time. Now, today, what I'm going to just tell you about the urodynamics, the importance of urodynamics in patients with neurogenic bladders. Okay. Now, as usual, when the bladder is usually filling at a rate of 1 ml per minute, 1 ml per minute. Now, as the bladder fills, in the initial part, there's just a transient rise of bladder pressure within the bladder, and then it maintains this pressure for a considerable period of time till around 400 ml of urine is there in the bladder. And this is the second phase in the storage phase. Here, the pressure of the bladder does not rise, and this is probably due to an inherent property, fibroelastic property of the bladder wall itself. Then towards the end filling, there's a transient rise of pressure till you ultimately go into the voiding phase where there's an abrupt rise in bladder pressure. Now, how is this seen in an urodynamics way? So this is very well covered by Sir. I think I won't go into this. Just wanted to tell you that storage phase and voiding phase are the 2 phases. In a day, more than 99% of our time is we are in the storage phase, and voiding phase is approximately just about 1% of our time. So I think this is very, very well covered by Dr. Banerjee. Then coming back to this, now when you take this picture and transmit it into the urodynamics, the picture is something like this, okay? The initial filling phase of the cystometrogram, okay? You get a straight line, and that is as the bladder fills, there is no rise in bladder pressure. And you can see from that the phase 1 and phase 3, you cannot see it in this. It gets merged in this diagram till when the time comes for void and there is a sudden rise of bladder pressure. Okay, this is keeping this idea in mind. I shall be just going through the basic about how to interpret a neurodynamics. Now, this is how this thing comes. Can I have the marker, please? Just thank you. Okay, this is how a urodynamic tracing comes. This is the first page of the urodynamics mission. This graph, the first graph that you see, this is the all important graph that you need to concentrate on. You can see that there are 4 rows over here. You just need to concentrate on the 3rd and the 4th row of this graph. This 3rd row is due to the detrusor pressure during filling, and the 4th row is the voiding pattern. This is the voiding pattern that you see in filling. The 1st and 2nd is the vesical pressure and the abdominal pressure, and this detrusor pressure is usually obtained by subtracting the vesical pressure from the detrusor pressure. And as the filling starts, you can see that there's no rise of pressure, there is no rise in pressure, and that means this is detrusor stability. Till at the end filling, there's a transient rise in pressure. And when the voiding starts, this is where the voiding starts, you can see that there's an abrupt rise in vesical pressure and the patient voids normally. And then you can see that there is, and on top over here, you can see the sphincter activity, that there is sphincter silence. This is normal voiding. This is the normal. You need to concentrate on the 3rd row and the 4th row. And this is what, again, the filling phase, it is the filling phase, and this is the voiding phase. The filling phase, what you have seen over here, it is replicated over here. Next page, on the next page of the graph, you see the voiding phase of this patient, which I've shown. Again, in the 3rd row, you can see that there's a rise in detrusor pressure and the patient voids. Okay, this is normal. This is normal. And there are various figures which keeps appearing in the urodynamics. What you need to concentrate on is this figure on the P detrusor at maximum Qmax. P det Qmax, that is the detrusor pressure at maximal flow. What will be the detrusor pressure at the maximal flow? That is, you need to concentrate on the figure. I shall explain that to you later. This is the 3rd phase. Again, this is figure that you need to concentrate as the opening P det. I've just underlined it because a lot of figures will come that is only there to confuse you. You don't concentrate on that, okay? And these graphs are all just supplementary on whatever you are trying to interpret on the urodynamics. And this is the final page of urodynamics, where all of you, most of you, you read this basically conclusion, and you come to our dynamics as to what needs to be done. Next. This one. Now, this is what Sir had initially told us, that this is the picture of what is known as the Detrusor Hyperreflexia, suprapontine lesions. Okay, in suprapontine lesions, what you see in this graph, that in this, during the filling phase, there is this abrupt rise in detrusor pressure. Abrupt rise in detrusor pressure during the filling phase. Okay, and where you are expected to have absolutely no rise in detrusor pressure, you are having this pressure. These are features of detrusor instability. And detrusor instability, and sometimes, and each one, some of them, they're associated with leaks. You can see there's a leak over here, till when the voiding comes and the patient voids, and here's a significant voiding over here. Okay, so during the filling phase, if you get these contractions, these are features of detrusor instability. And if it is associated with a neurological lesion, it is called detrusor hyperreflexia. This is suprapontine lesions in urodynamics. Now take a look at this. That this is what I wanted to show you, that this is, along with every urodynamics, you have what is known as the sphincter electromyography. And you can see that during the filling phase, there is intense activity of the sphincter muscle. And this is manifested in what we call as the EMG roar. The EMG roars at the time of bladder filling. Till we come to the place of voiding, and when the patient voids, the detrusor pressurizes, there is voiding over here, and there is complete EMG silence. That means the detrusor sphincter relaxes, and there is silence. So during filling, there is detrusor roar, and during voiding, there is detrusor silence. Take a look at this. Again, the patient, there is filling, the filling of the bladder, there's no detrusor overactivity, and the patient starts voiding over here. There's a rise in detrusor pressure. The patient is unable to void, and look at the sphincter. There is sphincter activity during voiding. You can see that the sphincter is absolutely roaring during the voiding phase. This is detrusor sphincter dyssynergia. Infrapontine suprasacral lesions. You can see that the detrusor pressure is again rising. The patient is unable to void, but where you are expected to have an EMG silence over here, you are having roar during, you're having activity during the voiding phase. The same patient, again, when you look at the voiding phase of the graph, you can see that there's high detrusor pressure over there. The patient is unable to void, and there's intense sphincter activity during the voiding phase. This again, this is the same patient. This is detrusor sphincter dyssynergia. This is the third patient. Okay, this is the patient. Again, you can see that as the filling starts, there is again no activity there. Absolutely. Towards the end of the filling, there's a slightly rise in bladder pressure. But as the patient starts to void, there's a decline in detrusor pressure. The patient decline in detrusor pressure. The patient is unable to void. And there is a sphincter activity is silent. So the decline in basically detrusor pressure. This is a feature of hypocontractile bladder. This is our infrasacral lesions, which sir had very, very well put it to us. This is the same patient. You can see that there's a decline in the detrusor pressure that with the patient is absolutely unable to void during the time of void. So the three important classical pictures in urodynamics: detrusor hyperreflexia, detrusor sphincter dyssynergia, and hypocontractile bladder. And the way how you have to look at these graphs in the urodynamics and see them. And this is ultimately the most commonest form of urodynamics pattern that we urologists are used to. You can see at the time of filling, there's intermittent, very small rise of detrusor pressure, okay? Until ultimately at the time of voiding, there is a huge rise of detrusor pressure and the patient is unable to void. This is bladder outlet obstruction. This is bladder outlet obstruction. This is pressure, patient is unable to void with huge bladder pressures. Again, you can see the same picture during the voiding phase. Again, the huge rise of detrusor pressure, and you can see that the patient is unable to void. This is a mechanical obstruction, and this is probably which we urologists see as bladder outlet obstruction due to benign prostatic hyperplasia. This kind of patient. And here in this, in particular, these values of P-det Qmax or opening P-det comes into significance. You can see that the P-det Qmax is more than 100 centimeters of an opening P-det is around 100. This is a classical example of bladder outlet obstruction. So I think with this, I think people, next time when every neurologist, neurosurgeons would be getting urodynamics in your hand, you should be able to look at the graph and interpret the various lesions and where it lies. Thank you very much.
Thank you, Dr. Pathak. Now, we are being joined by our second panelist, Professor Atanu Biswas from FIAN, Kolkata. And
good evening, everyone.
Good evening, sir. So,
sorry for being late.
No, we want to hear from you about your experience with neurogenic bladder. How do you deal with patients with neurogenic bladder?
I think Dr. Banerjee has given a very good overview about the bladder physiology and the symptomatology and the management, everything. To me, and Dr. Pathak has also given the aerodynamic features of different types of neurogenic bladder, as well as that the common lower urinary tract symptom that is seen in elderly persons with the bladder outlet obstruction. So, for a neurologist, it is very often, quite often we come across patients where it is difficult to differentiate between whether it is bladder outlet obstruction or it is a neurogenic bladder. So we as in a neurologist, we try to find out the symptomatology of the patients, and of course a detailed clinical examination of the patient is very essential to look for whether there is any lower motor features in the lumbosacral region. There is any sensory loss, and there is hyperreflexia in the lower limbs, or there is any clinical feature suggesting that there is a myelopathy of the dorsal cord or the cervical cord. And sometimes it is very difficult to differentiate, and we take the help of the aerodynamic study to look for the pattern of the aerodynamics to determine what is the type of bladder dysfunction the patient is having. And very often we come across to patients, elderly patients who are incontinent, and even after detailed investigations, it becomes difficult to find out. Many elderly patients are incontinent because their cortical functions are not the suprapontine lesions that Dr. Banerjee and Dr. Pathak has already told. There is a symptom of precipitancy. Once they get the urge and they void a large amount of urine at a time, so there is impaired feeling. So the bladder contracts quite often, and that happens in very elderly persons, particularly those who are having the neurodegenerative diseases like dementia or the Parkinson's disease. And but for a neurosurgeon, I think the most important cause for neurogenic bladder is either the lumbosacral radiculopathy or the Cauda-Equina syndrome, producing the lower motor type of sphincter dysfunction or the bladder dysfunction, or there is a spinal cord injury or spinal lesion producing the detrusor sphincter dyssynergia, leading to because of the infrapontine suprasacral lesions. So this is what I.
So I want to ask the speaker and both the panelists. So who are the patients that you commonly refer for urodynamic study? Dr. Banerjee?
Yeah, actually,
what kind of neurological or neurosurgical patients
well,
we should refer?
If I get to see a patient who has urinary problem, we are encountering patient with bladder dysfunction, I ask a few questions. First of all, whether he has a sensation of bladder filling, and whether there's urgency, hesitancy, or delay in micturition. So all these questions are asked, and we try to figure out whether this can be explained by. Very often we get to see the uninhibited bladder in the elderly. Patients with Parkinson's disease, patients with dementia, they do have this urgency. But at the same time, these patients also at this age group may have obstructive pathology. So many of the patients, before we ask them to take medicines, which are bladder sedatives, the mirabegron or your colterodine and all those things, I do a KUB ultrasound study to see if there is an obstruction there. Post-viral is a male, could be a enlarged prostate. Because if we give medicines there, one can have retention of urine. And definitely I take help of my urology colleague to rule out obstructive pathology before I can say conclusively that's entirely due to a neurogenic cause.
So, Dr. Pathak?
Yes, I think one of the very, very common types of patients that we encounter while working out for LUTS, lower urinary tract symptoms, is that we ask these patients whether they have low back pain that is radiating down the legs, even going down below the knees to the or any tingling sensation in the limbs. And along with the bladder dysfunction, also the third question that we ask is, are they severely constipated? And so if the constellation of three of these symptoms of a low back pain radiating down the legs, along with an obstructed voiding and with an obstructed defecation, if these are there, then we suspect that the patient could be having a neurogenic cause to his bladder symptoms. But having said that, okay, it is very, very difficult. The only one way we can settle the issue between a hypercontractile bladder or this thing, or a prostatic obstruction, both of which are causing similar types of symptoms as far as retaining urine in the bladder, will be only be resolved by the help of urodynamics. As I've showed you in the urodynamics, in obstructive and prostatic obstruction, you have a high pressure, low flow, whereas that in hypercontractile, you have a low pressure, low flow. This is the only way I think we can differentiate and like treatment, as you say, if you can remove the obstruction as far as the BPH is concerned, and for hypercontractile to establish the patient on CIC.
So what are the subset of patients? So Dr. Banerjee, who you refer for urodynamic studies?
In my patients, number one is that other than urological causes, there are urological causes. There's a failure of medical treatment.
Patients we see from the neurological sites.
From the neurological sides, yes. I think there's a whichever patients, I think, because severe overactive bladder overactive syndrome, the overactive overactivity, patients going to the toilet 15, 20 times, not just that, isolated nocturia, it is investigated on its own separate lines altogether. A severe overactive bladder and this the low back pain with obstructed voiding. These are the category of patients from which I think we subject them to, or even in the post-operative patients. I think, Kaushik, you do a lot of spinal surgery. After that, the patient gets into retention and then fails the catheter trial. Even after that, these are the patients we would subject them to a urodynamic study.
So, Dr. Banerjee and Dr. Biswas, so what is the protocol of urological management, say in a case of a hemiplegic or a quadriplegic patient? What do you follow in your practice?
In paraplegic patient or in a quadriplegic patient?
Or a hemiplegic patient with CVA?
Okay, if the patient has retention of urine, first thing you have to, allow him to void urine. We have to put a catheter. That's the first thing that we do. And then, if the patient is bed-bound with paraplegia and hemiplegia, the patient has to be on a catheter because it's quite expected that the patient will not be able to, pass urine. So retention urine is a major issue when a patient comes. After that, we after some time when the patient recovers, suppose, then we gradually take out the back catheter. Depending on how long the catheter has to be there, the patient can fill the urine. If the patient has been on catheter for a long time, we intermittently clamp and allow the bladder to attain its size, and then gradually take off the catheter and see whether he is able to void urine. But many a times, these patients will have, particularly paraplegic patient, may have the problem with urinary dysfunction, not being able to really pass urine either because of it can't squeeze urine properly, or it is because of detrusor sphincter dyssynergy or what is happening. So many of the patients are left with having a catheter, either indwelling catheter, or maybe they'll be having this CISC clean, intermittent self-catheterization, that sort of thing. And then if the pathology recovers, then fine. We'll, the patient becomes ambulatory, maybe we'll be able to achieve normal.
So, Dr. Pathak, can you tell us what should we explain to the patient while advising CISC?
CIC, essentially, firstly, we have to demonstrate it to the patient. That is the most important thing, that we have to convince the patients that in hypercontractile bladder, if a tonic bladder, CIC is the only modality of treatment. It is the only modality of treatment. Bethnecol, fine, it is, but the dose at which we give Bethnecol, it is probably much less. The normal dose ideally should be given Bethnecol at 200 milligram per day, but we give it at 25 milligram thrice a day, 75 milligram of Bethnecol we give, because it's a procholinergic drug, and SIRS, I think, would be in a much better position to speak about the side effects of Bethnecol than I would. So establishing them on CIC, now how many times do we ask this patient to do CIC? Firstly, most important, if we take the patient off the catheter and the patient is voiding spontaneously, we need to take a look at how much of residual urine this gentleman is retaining. If he is not retaining any residual urine and he's taking a lot of time to pass urine, okay, we don't need to put these patients on basically on CIC. But if the patient is retaining large amounts of urine, okay, then these are patients that need to be put on CIC. The worst situation, 6 times a day, approximately in the morning, 6 a.m., 9 a.m., 12 noon, 3 p.m., 6 p.m., and 10 p.m. This is that time. And note the CIC volume, and every time that we put in the catheter to CIC. If the CIC volume is coming less, if it is coming, then reduce the number of CICs. If the CIC volume is coming higher, if it is higher, and every time you're passing a catheter, 600 ml of urine is being drained out, then at least you need to increase the number of CICs. So at no moment of time, you should allow more than 500 ml of urine to stay inside the urinary bladder. This is the protocol probably we follow. But again, having said that, if the patient is, we see a lot of hypercontractile bladder, the patient is taken off the catheter and they are in follow-ups, they are passing urine normally with retaining little amount of residual urine. These are the patients we probably just follow them with serial ultrasound. Most important thing about ultrasound is the silent deterioration of the upper tract. This is what we need to look at.
Shall I tell a little story? Our
Please.
Unfortunate young woman whom I sort of treated. This patient, she had sciatic pain and was discovered to have a Tarlov cyst between S2 to S4, that area. So it was probably hitting on the cauda equina. The patient did not have the surgery here. She went somewhere down south and had a surgery. And after that, I saw the patient a couple of years after that, and the patient came with a huge, she said that she's not able to pass urine. She's having a filling sensation, but she's not able to pass. That has happened of late. So I said, okay, let's take your history back. So 3 or 4 years ago, she had the surgery. She was working as a student nurse at that time. And she said that, well, I was able to manage by going to the toilet once a full day. So, and okay, when I was passing urine, not much of urine was coming out. But I was able to manage, I was not having the sensation of filling. Now I'm having some sensation of filling 2 or 3 years later, but I'm not able to pass urine. Actually, the patient was retaining urine right after surgery. The patient had a very damaged cauda equina and the patient gave rise to Atonic Bladder because the sensory component was also damaged. She could not get the sensation of filling. So there's a huge bladder of filling over 1 liter of urine.
Yes.
So that was a patient. Now probably some amount of sensation has come back. She said, okay, I'm having some distress, but I'm not passing the urine. And only once a day
Right.
going to the toilet means the patient was having a huge amount of urine. That's a classic
Absolutely.
symptom of atonic bladder.
Right. Right. So we,
So
sir,
when I say that your only option is to go for CICS,
absolutely.
and the patient was, what can she have? What kind of life will she have? But at least a life which is free from the risk of infection, but still there is a chance of infection. That's all she can have. That's the story of a person who has atonic bladder. So surgery in the region of Cauda equina
Yes.
and in the S2 to S4 region, one has to be very cautious that it doesn't give rise to urinary dysfunction.
Right.
And Professor Vishwas, so what are the drugs as neurologists and neurosurgeons we can prescribe at OPD for patients coming with incontinence or retention? What are the common drugs we can prescribe without taking the help of the urologist?
So that thing Dr. Banerjee and Dr. Pathak has already told, that depending upon the type of the bladder, you have to choose the drug. If it is hypoactive bladder, you have to use the methanol, and so that the bladder contraction can take place by using the cholinergic drugs. Of course, Dr. Pathak was talking about the side effects and the dosage. The dosage, yes, we usually do not use that much of dosage as Dr. Pathak was talking about. But yes, side effect is a concern. Usually the cholinergic side effects are the nausea, vomiting, diarrhea, and like those. But that needs to be taken into account before prescribing. But for the hyperactive bladder, so Dr. Banerjee has already given the drugs used for that are the beta-adrenergic and also the muscarinic receptor antagonist. And usually these drugs are used for those who are having the hyperactive bladder with Detrusor Sphincter Electromyography. These are the tolterodine and like those, I forgot the name, muscarinic receptor antagonist. But you have to determine the type of bladder the patient is having before prescribing these drugs from the OPD. For that require a clinical assessment, and also sometime if you need to do the ultrasonography to find out the residual volume of the urine and also the urodynamic study.
There's a question in the chat box whether the detrusor pressure and vesical pressure are the same.
Abdominal detrusor pressure and vesical pressure. No, no. The detrusor pressure, again, I'll tell you, the detrusor pressure is the vesical pressure minus the intra-abdominal pressure. The intra-abdominal pressure. Precisely when we do urodynamics, okay, we have two catheters. We have two catheters, one inside the rectum, one inside which measures the intra-abdominal pressure, and one inside the bladder. And there's a third catheter which fills the bladder, okay? And we get various stages. I think that's an elaborate topic to talk about urodynamics, that first sensation of voids, normal sensation of void, strong desire to void, and each one has a very, very significant neurological pathways, which the sir had beautifully told us, Dr. Banerjee told us. So essentially the detrusor pressure is a subtraction between the vesical pressure and minus the abdominal pressure. You see, I had showed you there are 4 rows, okay? The above 2 rows, the up top 2 rows is the vesical pressure and the abdominal pressure. If they are subtracted on the 3rd row, you get what is known as the detrusor pressure. And you concentrate on the detrusor pressure to come to an interpretation. You come to the interpretation, this thing. There are other ways, abdominal straining. Sir had shown us a beautiful uroflowmetry of a straining pattern in patients with DSD. And DSD, that is manifested aerodynamically when we see about the sphincter, which I showed you, which I showed you, the sphincter.
And I have a last question, that as pediatric neurosurgeons, we see a lot of children with tethered cord and coming with a lot of neurogenic and urogenic bladders. So what is the minimal age that we can refer them for urodynamic study? So
well, we have seen. I've seen Kolanda himself taking care of urology at a very young age. Okay, but I probably have very little experience about in patients absolutely born 1 year or 2 years. Okay, probably if the urodynamics has to be done in this category, it has to be done under anesthesia. It has to be done under anesthesia.
no, but it is possible to get interpretation.
Yeah, interpretation.
Because we need to do a neurodynamic before deteriorating and after deteriorating from the medical legal point of view. To see that
urodynamic. See, the fundamental thing, any neurogenic bladder means urodynamics. Okay, and then you proceed to, you either have 3 categories. You have a Detrusor Hyperreflexia, you have a Atonic Bladder, or some DST in between. And likewise, absolutely, in the 3 categories, you have
we can refer children, say 1 year age or 1.5 years age for
you have to establish. For any neurogenic, you must have urodynamics to establish your diagnosis. Yes.
So,
But very difficult to do urodynamics in children. I think it has to be done under sedation or under anesthesia. You have to keep them quiet. These essentially, basically the entire procedure is just catheters that go into the rectum and the patient just lies quietly. There's a bladder filling that goes on, and at every moment of time, the patient either sits on a chair or is lying on a couch, and he just keeps telling the investigator that yes, this is the first sensation I'm getting to void. Ultimately, when he just cannot hold on, he says, I have to void, and then he's asked to void. This is what the urodynamic, how all the investigators who carry out the urodynamics do. What I've just highlighted over is to interpret the urodynamics.
Since there are no other questions in the chat box, we have come to end of this exciting seminar of today. And I thank Professor Dr. T.K. Banerjee, Professor Biswas, and Dr. Pathak for your wonderful participation and illuminating us about our very difficult topic. Thanks all of you.
Thank you very much
from the Power Clinic. And we'll be back after on 19th August with our next topic, which is on blood-brain barrier and ICP, understanding the basics. And I now hand over to Mr. Deepak for his vote of thanks and conclusion.
Thank you very much, Dr. Kaushik Sil, for coordinating this session. I must thank on behalf of Health NU, our speaker, Dr. Tapas Kumar Banerjee, who elaborated this difficult subject for a neurologist, control of micturition, what can go wrong, extremely well. And Dr. Himadri Pathak, Neurosurgeon, gave urodynamic aspects of this entire subject very lucidly. And Dr. Atanu Biswas, our panel member, added the value in this entire session. So on behalf of Health NU, I would like to thank speakers, the panels, and the coordinator. And this webinar series is conceptualized by Dr. Sandeep Chatterjee, so I would like to thank him also, though he's not present here today. And on behalf of Health NU, I would like to thank all the audience who came in large numbers for this very interesting topic. We got 128 audience today for this webinar. So this webinar series have been very successful, having more than 100 plus audience every time. So this is Deepak Naik signing off on behalf of Health NU, thanking all of you for taking this time out from a very busy schedule, today being a working day. And we will meet once again on Thursday, after the next Thursday, for another interesting session from Basics in Neurosciences, organized by Power Clinic and DigiNeuro from Health NU. Thank you very much. Good night to all of you, sir. Thanks a lot.
Thank you. Good night. Good night. Thank you all.
Thank you, sir. Thank you.
Thank you so much.
Sir, thank you very much.